to welcome you all in our meeting today. One of the online courses hosted by Benha University, Orthopaedic Department of Benha University. I'd like to welcome all my colleagues who attended this meeting today. Dr. Elashhab said that we have guest speakers from UK, from Canada, from Brazil, from India, from Switzerland, and definitely our colleagues from Egypt who are specialized in shoulder surgery. It's a great pleasure for all of us to meet with a great number of attendees. Dr. Elashhab told me that one of the orthopedic channels or one of the TV channels in India is transmitting also our meeting today. It's a great pleasure for all of us to welcome our colleagues from India. And we can say that this crisis or unprecedented crisis presented by COVID-19, we have taught a lot of lessons. One of the most important lessons we have taught in this crisis that how we can help each other to turn the crisis into an opportunity. Definitely the virtual meetings hosted at least by the Orthopaedic Department in Benha University prove this idea that we can meet in a great number, even if we cannot attend the great events or great conferences. We can meet not only in hundreds, but even in thousands of attendees or orthopedic surgeons. I'd like to welcome you all and wishing you a fruitful specialty day presented by our colleagues from specialized in shoulder surgery. Thank you, Dr. Mohamed, and a great pleasure to meet you in our orthopedic meetings.
Thank you so much, our beloved Professor Adil Adawi, the President of the Egyptian Medical Association. Now we will come to the talk of Professor Gamal Hosny, the President of the Orthopaedic Society of the Orthopaedic Association of Egypt. Professor Gamal.
Thank you, Mohamed. Thank you. Good evening,
much.
everybody. First of all, on behalf of the Egyptian Orthopaedic Association, I would like to thank Professor Mohamed Elashhab, the Dean of the Benha Faculty of Medicine. And I would like to congratulate you for being appointed as the Dean of the Benha University, and I wish you,
so much.
All the best in the new term of being the Dean of the Benha University. I would like to thank the guest speakers from different countries who are going to give their presentations today and tomorrow. And I would like to remind everybody with the activities, the recent activities of the Egyptian Orthopaedic Association. The next Wednesday, we have our 17th International Deformity Conference. It's going to be a hybrid. In the morning from 8 o'clock till 4 p.m. we are going to have face-to-face presentations, and then from 4:30 till 7:30 we are going to have the virtual program. So it's a mixed program and for 3 days, and I would like to see all of you to participate in the meeting. We know in the Egyptian Orthopaedic Association we are always encouraging the scientific activities, especially the online presentations and the online teaching programs. The most important of them are Benha teaching program developed by Professor Mohamed Elashhab. Online teaching came to stay. Whatever happened afterwards, after the end of the COVID-19 era, we are going to continue our online teaching and virtual programs because we find it's very fruitful for exchanging the ideas between different parts of the world. You know, we are all seeking for the improving the health and the alleviating the pain of the patients. And this is not just in Egypt or in the Arabic countries, it's all over the world. So the doctors or the scientists have to exchange the ideas for the healing the problems and the diseases for all over the world. So finally, I would like to thank Professor Mohamed. I would like to thank all our guest speakers. Dr. Mohamed Imam, thank you for being with us in this meeting. And let's start the meeting, and I hope it's going to be very fruitful. Thanks, Mohamed.
Thank you so much, Professor Gamal Hosny, the president of the Egyptian Orthopaedic Association. Thank you so much, sir, for announcing officially for the beginning of the Shoulder Specialty Days. Our first speaker will be Professor Mohamed Imam from London East University. It's a great honor to be with us, Professor Mohamed. Thank you so much for joining us tonight, sir.
It's a pleasure. Is mine, Dr. Mohamed and Professor Mohamed, and thanks a lot to Professor Gamal and Professor Al-Adawi for opening this, and for everyone who are undertaking this brilliant sets of webinars, which has been very educational and informative for many surgeons all over the globe. And I've been told a huge amount of positive feedbacks from different surgeons and trainees all over the globe. So I'm going to talk in the next 20 minutes or so about rotator cuff disease. We're going to talk about 11 myths debunked about rotator cuff disease. I'm a consultant trauma and upper limb surgeon at the Royal Prosto Orthopaedic Unit, and I'm a professor and medical director of the Smart Health Academic Unit at the University of East London. And it's always a pleasure to attend these meetings organized by Benha Orthopedic Department, as well as prestigious and one of the oldest orthopedic associations in the world, the Egyptian Orthopedic Association. So we've evolved a lot over the last 100 years. However, our shoulders didn't really evolve that much. So what a 60 years old would do nowadays routinely wouldn't be even a possibility 20 or 40 years ago. And in order to approach these problems, we have to understand the complex nature of shoulders for sure. And we always have to approach these patients in a bespoke individualized pattern. So why I'm going to talk about rotator cuff disease? Because one, shoulder pain is the third most common presentation of musculoskeletal pain in primary care after neck and low back pain. And out of 9 million patients presenting who are older, over the age of 60, 60% of them would have cuff disease. And with rotator cuff disease, and actually the majority of shoulder problems, we can diagnose almost 90% of the time just by history and examination. So having a holistic, comprehensive approach to these patients would enable us to identify the problem. So what do we need to know? So rotator cuff disease is actually a sequelae of events, starting from subacromial impingement to calcific tendinosis, partial and full thickness tears, as well as cuff tear arthropathy. And one myth we always see with patients is patients saying, my pain is actually in the arm, it's not in the shoulder. How come I have a rotator cuff problem? And actually 99% of these patients will have pain down the arm towards the deltoid muscle insertion. And that's usually the first question I would ask and recommend to ask when you have a patient with a shoulder pain. And we diagnose subacromial impingement with the 3 Ps: pain, painful arc syndrome, in which the pain is always between 60 and 100 degrees, and doing the provocative test like Neer test and the Hawkins and Hawkins tests. So important myth here that many do not really appreciate, especially in GP practice and some orthopedic surgeons, is that subacromial impingement in the majority of the cases are symptoms. It's not a disease in itself. So we have to understand first what is the rotator cuff. We have to understand that the rotator cuff are dynamic stabilizers for tendons. They have the main function of a comprehensive compression concavity function, or the pumping action. So the rotator cuff tendons surround the humeral head as a baseball glove surrounding the baseball itself. And the main function is to keep the humeral head in front of the glenoid so that we can have the extensive range of motion in shoulders. And if there are any problems, then patients might have subacromial impingement. We have to understand the different anatomy we have compared with apes. We have in humans, the clavicle is lens, and the scapula moves to the back, and the glenohumeral joint is externally rotated. And actually, impingement doesn't mean an acromial spare. We now understand that impingement can be a secondary symptom to three big categories, either postural, which is impingement by itself. All what is needed there is for the patient to correct their posture, or can be related to cuff dysfunction or a space occupying lesion. So acromial spare is actually 1 out of 10, but it can, all of these conditions, including cervical disc disease, can cause problems, either cuff dysfunction or space occupying lesion. And that's why 2/3 of patients with shoulder pain will have positive impingement tests. One common problem to understand is the postural impingement, and that's actually has been extremely common nowadays, with patients sitting, with all of us sitting on our laptops and desktops working and having weird postures, and that would lead to shoulder pain. And all what is needed here is actually a correction of the posture of patient in order to overcome the impingement lesion. And you in clinics, you can easily identify that by doing scapular assisted correction of the problem, and the pain usually improves significantly just by asking the patient to repeat the impingement tests with correction of the posture. So advice to patients is all what is needed. A physiotherapy program for postural impingement would be more than enough. So if these patients have the 3Ps and you do x-rays and you find calcification, that's the second bit of rotator cuff disease. It's very common nowadays, and ultrasound guided needling and parpotage has significantly helped with this problem. And actually, this is one of my patients. We've done an aspiration, an insertion of application of saline, and you can see you can aspirate a lot of the calcium out of the shoulders. And actually, the interesting bit nowadays, mainly because of the advent of ultrasound guided parpotage, the number of patients that we have to operate on and release the calcium has significantly decreased. And the success rate of parpotage is estimated to be around 70 to 75%. And you can see that draining the calcium is not technically demanding, but and it is really interesting what you can achieve. So what about partial tears? We used to think that partial tears can be managed with steroid injections, but the more we understand about shoulders, the more we get the concept that actually a steroid injection has the risk of possibly increasing the size of the tear. So if we manage it mainly now with physiotherapy or repair. And repair, there are two techniques we originally talked about, either completion of the tear and repair, and some advocates of that technique would say because the tendon is not really of good quality, second option is in situ repair. However, nowadays my preferred option is actually doing biologic graft, Regeneten, which is popularized by Smith and Nephew, and it's a quick procedure. The last one I've done a few days ago would take took less than 10 minutes actually inserting the graft, and the results are very promising utilizing this technique, and we have very promising results with this technique. And as I said, it doesn't take long. And actually, recovery and rehabilitation after this technique is very quick. We are observing very good results so far. And the patients, I don't keep them in a sling, and we start mobilization as soon as we can. So we know from the paper published by Yamanka that up to 80% of these might progress to full thickness tear. However, with the advent of physiotherapy and exercises, and we understand things more, and we understand who to operate on and who to manage non-operatively, I think that the figures has decreased significantly, and the recent evidence say it can be up to 40%. So what about full thickness tear? It is one of the most common problems we see in shoulder clinics. And as all of you, we can categorize them into degenerative and traumatic tears. We can manage them with physio or repair. And usually we find that GPs referring patients based on scans demonstrating a rupture of the tendon, worried about it, but who should we operate on? Usually the simplest solutions aren't usually the right ones. And so we look into the evidence and we contributed to the evidence to see what do we really need to know and what are the outcomes, what are the financial burdens, and what is the natural history of rotator cuff problems, including hearing rates and clinical outcomes, and what are the options that we can utilize. And quickly, we know now that traumatic tears we always have a low threshold to operate on most of them. However, with degenerative tears, there is evidence saying that it might be associated with, we can manage them non-operatively with physiotherapy. We know that it is if you scan 100 persons walking in the streets, 50% of them might have a tear, and we know that the majority of these will be asymptomatic patients with no problems at all. The problem here in the evidence with large and massive tears, there is increased risk of recurrence. So as an orthopedic surgeon sitting in my clinic, how can I manage these? We actually looked, the evidence highlights that actually non-operative treatment can be an option. But what about surgery? Surgery in this seminal paper by Robinson, looking at 1,600 patients, they found that, and we know that now, the rotator cuff surgery is significantly successful. And actually, we know from this paper by Millet that the outcomes can be maintained for a long period of time after cuff repair. And we know from this paper by Antoni that the majority of professional athletes can return to the same sport and the same level after surgery. So who to manage non-operatively and who to manage with surgery? There is a myth saying that we don't repair tears in old age. Actually, we do. And Christian Gerber usually would tell me during fellowships that age is just a number. And we totally agree. And Rashid has published a paper saying that age is not a big deal. And actually, we looked at 120 cuff repairs we've done, and we had as many as other authors, and we found that the main important bits is the tendon quality and tear size and physiologic age of the patient. So we've undertaken a review looking at age. And we found, and actually this is a classic paper which demonstrated that age actually doesn't have a significant impact and on outcomes after cuff repairs. We did this review, which was published last 2 years ago, and we found that the 3 B's are the most important bit, which is the patient, the pathology, and the participation. And looking at the published evidence, in my hands now, I think the most important bits to decide whether to repair or not is the physiologic age of the patient as well as the fatty infiltration. So if the patient has fatty infiltration of more than 50%, I would opt for non-operative treatment. Always be cautious with smokers, those on steroids, and definitely patients with arthritis. So we looked at different repair techniques as well. We know arthroscopic repair has become the gold standard now, although the evidence says that possibly non-operative open repairs also has a role. We looked at in this RCT at 3 years about whether to go for single row or double row, and we found at 3 years there is no difference between single and double row in small and medium tears, and there is significant superiority for double row repair in patients with large and massive tears. And subsequently, we now, if I have someone with a small or medium tear, I'll just do single row because there is no difference. It's quicker and earlier recovery and quick recovery. While if someone has large or massive tear, I'll opt for double row repair. So we also looked at patients' expectations, and we found that the majority of patients has 2 main problems here. One, the pain, and second is the range of motion. And after cuff repairs, the scores and the functional outcomes continue to improve up to 2 years after surgery. And the majority of patients will be, 90% of patients will be satisfied at 2 years from surgery, and their expectations are met. One important bit to understand is that you have to have realistic counseling with patients about the current, about rotator cuff repair and what they should expect. So we know also, so in our review, we found that symptoms are not consistent with tear size. So you can have someone with a small tear with significant limitation and pain, while others with significant, with large tears with good function and no problems. So what about timing? So for traumatic tears, we know that surgery in the first 6 months is associated with significant outcomes, and that's according to this paper published by Duncan. What about healing rates? So interestingly, all the evidence published about massive and large tears up till 10 years ago has reported significant amount of re-tears. But does it matter? Actually, of course, as expected, healed tendons will have better functions and the patients will be happier. But actually, those with who will have a re-tear or unhealed repair will have satisfactory function compared with their preoperative level. So having a re-tear is not an indication for another repair, but actually you will find that patients continue to have some improvement according to this paper by Robinson. So what about cuff integrity? By Kim also looked into that, as well as Mouricio, and both of them found that although some patients might have healed tendons compared with those with a re-tear, but the functional gain is almost similar. And this paper by Lee, they found that the most important aspect for counseling patients is the size and the fatty infiltration of the tendons. So what about traumatic incidents? There is a high significant, so with traumatic tears, we know that we have to operate on them in 6 months. And actually, if you operate on someone with a traumatic tear more than 2 years down the line, the outcomes are inferior. So what happens natural history-wise if we don't repair this? The worry would be losing the concavity compression action of the cuff, and patients might ultimately develop rotator cuff arthropathy. And there are different ways of managing rotator cuff arthropathy, which is the last bit of rotator cuff disease and the last ultimate end in some patients who the pathology would continue to take its course of action. Physiotherapy, and now we understand the importance of anterior deltoid strengthening, core strengthening, and improving the kinetic chain. And physiotherapy would be the first line of treatment for all these patients. And if fails, then a reverse shoulder replacement, putting the deltoid at a biomechanical superior lever arm so that the deltoid can overcome the deficient cuff tendons underneath. So natural history, looking at patients who wouldn't have repair, Ranibo found that the development of full thickness tear is huge, and actually 40% with those with partial tears will develop full thickness tears and will develop the cuff tear arthropathy in 40% of the time at 22 years down the line. And we know from this paper by Maman that the main risks would be old age, here patients older than 60, those with full thickness tears, and those with fatty infiltration, which was the evidence published by Christian Gerber as well. So do we have to repair tendons? Financially, Matter et al. Has looked at different aspects, and interestingly, which I think is a very good paper, they found that actually, if you do repair, you save the patient $13,000 on average. However, the savings can be as high as 77% $1,000 for those who are 30 to 9 to 40 years, and about $11,000, or actually almost $12,000 for those who are between 70 to 79 years old. And they estimated that this would save a huge amount of dollars per year if you opt for repair. So what is the future? Just to summarize the future of cuff healing, we know there are different aspects, and now we're looking into alternatives and how to improve healing. We looked at in this book, as well as in different studies, about biologic repair. We know that inflammatory process of healing is associated with growth factors, and there are many growth factors identified. There was an initial interest of doing platelet-rich plasma and stem cells injection in patients with augmentation with repairs. The evidence is not really supportive of adding PRP and stem cells as yet, so especially bearing in mind the cost, and so we're still not shifting into going for that. We looked at augmentation, either biologic, like what I've shown you before, or structural augmentation, especially with patients with fatty infiltration as well as large tears. We wrote that technique and we wrote our results. We have different concepts and different graphs that's used. A lot of studies has been published and more are continuing to be published. With xenografts, the results wasn't very satisfactory initially, and things appears to be improving over the years. Actually there is more shifting into augmented repairs in certain selected patients. We looked at our experience and we published our 1-year results, which included 36 patients, and we found that we can achieve a healing rate of around 80% in those patients. Second, future number 3 would be gene therapy and nanosurgery, which is only and predominantly being done in the lab, not used clinically yet, but it can help with those patients with rotator cuff disease. Finally, for rotator cuff arthropathy, we are shifting into using navigation and virtual reality, and there are a lot of aspects, a lot of work now being done on the utilization of virtual reality, machine intelligence, artificial intelligence, and in our Smart Health academic unit, we're looking at these aspects and how to improve the outcomes of patients undertaking different replacements, mainly shoulder arthroplasty. So irreparable tears, to cover the whole topic, there are different options, starting from balloons, tendon transfers, superior capsule reconstruction, and augmented repairs. We stopped doing the balloons because the evidence actually wasn't very supportive, bearing in mind the cost and all aspects. It is a technically challenging problem, especially in young patients without arthritis. There is a strong rule for physiotherapy in the form of anterior deltoid re-education. There is evidence published as well about, especially in elderly patients, about suprascapular nerve ablation, arthroscopic debridement. Howie, as well as Walsh, said that it can be successful in up to 70% of the time. However, that doesn't stop progression. Partial repairs of the rotator cuff is another option, and the evidence says it might be better than doing nothing. And the rate of repair failure is almost more than 40%. For augmentation, as I mentioned earlier, like the hamburger technique, which you published, or different concepts, and I'm sure many of the audience and the eminent surgeons would have different techniques, is also another one. Here I'm talking about augmentation of a partial repair, which can improve the outcomes, and we're looking at our data now. Balloon is out of favor now. spacer implantation didn't show significant outcomes, and now the main treatment options in younger patients would be either a tendon transfer, so lower trapezius, like the Mayo technique by Bassem and Hassan, or the latissimus dorsi transfer, which was popularized by Christian Gerber, which actually is becoming a very popular option in younger patients. A reverse shoulder replacement, if they have arthritis, is a treatment of choice and the gold standard. And finally, superior capsule reconstruction, in which we use a patch and to replace the tendon, and that would prevent progression of rotator cuff arthropathy. But in the selected patients, you will have better outcomes. Superior capsule reconstruction was originally popularized by Mehata, and the results in the rightly selected patients are promising and satisfactory. In Mehata's results was very promising, but he used fascia lata because patches weren't allowed in Japan. However, it is a commonly performed procedure, and in the right patient, we can achieve good outcomes as per the review we've done. Massive cuff tears, there are a lot of options, there are a lot of modalities we can use. It's still a bit confusing. The evidence is contradictory somehow, but thank you. I'm sorry for talking for a long time.
Thank you so much, Professor Mohamed Imam from East London University, for this very interesting talk. Thank you so much, sir. We will be very happy to receive questions from our dear panelists and attendees. Any questions to Professor Imam? Professor Raffaelli, you have any questions?
Dr. Imam, I just want to say that your presentation was fantastic.
Oh, thank you.
Because in a short time, you can talk about everything about the rotator cuff disease. And I agree with you about the pathology or the physiopathology of the disease, because we really don't know yet. It's not only impingement disease, it's not only a degenerative disease, but it's a conjunct of all these times. And I really think that we need to be some very good surgery or doctor to individualize each treatment. I don't think we just have to have a menu of treatment, but I really think, just like you, that we need to know a lot of ways to repair the rotator cuff. We need to know the anatomy of the rotator cuff to do the best for the patient. I just want to say congratulations. It's a fantastic presentation. I take some pictures of that, and I really love it.
Oh, thank you, Dr. Raffaelli. It's a pleasure.
Thank you so much, Dr. Raffaelli. Thank you so much, Professor Imam. Now to the second speaker. The next speaker will be Professor Mohy Taha from Zurich University, Switzerland. Professor Taha will speak about virtual reality in shoulder replacement. Professor Taha is now in Egypt, in the North Coast. I hope the connection are doing well, sir.
We hope. I hope you can hear me. I can hear you.
Welcome in Egypt, my dear brother.
Thank you.
We have Professor Adel Adawi with us, Professor Taha. Professor Adel Adawi, the president, of course, of the Egyptian Medical Association and the former president of Health and Population in Egypt.
Sure, it's
the North Coast
pretty well known.
How is the North Coast? You like it?
We love it. Kids love it. They burn themselves. I burned myself. Everybody is happy.
I hope the videos will be working, sir.
You can. He's muted. He's muted.
Yes, you are muted, sir.
Can you share the videos from your screen? I sent all of them.
Dr. Mohamed?
ايوه حاضر يا دكتور محمد، بنشيرها حالا.
Please share the videos. Mohammed, the videos are not working or what? Professor Taha, the videos are working, I think.
That's great. The audio, can he start it? It's already audio recorded.
Okay, sir.
Today I'm going to show you how to use the polarized tool. This is not time touching. Reality imaging, real and virtual worlds to produce new environments and visualization. In the following video, I will show what we can currently do with mixed reality and a case combining mixed reality and navigation. So here I have my scapula. Here I have my hand, so I can move it around. It is there. Check it. Oh, it's perforating here. Not a very good one. Here, no perforation. So let me move it again. Like this one. Here. Now it's looking better. It's a bit inferior. Let's move it around again. Now. Not bad. I have to legalize a little bit. Not bad.
لا بص انا كده الدنيا تمام، انا بشير الفيديوهات اهي. الراجل اللي هو دخل بس هو انا اللي بشير الفيديوهات بس.
Also not bad.
طب ماشي، انا هرد ساعة دكتور محمد.
You see here you have some perforation. If I look at mine, I have no perforation.
Hello everybody, today I'm going to show you how to use this tool to show your patient actually what you see in your programs. I start with my computer, my Teams to my programs. So now I just start the diagram, which is already
repaired. Here, ready to go. So we can show the patient what he really has. We can have it in any position. We can put it in the table and fix it, and then you can sit around, show the patient. You can say, ah, you can put it in the table. How does it look like? And your patient is fix it again. You can make it bigger. You can take it. You can go marker diagrams. You can give it back to you. That's all. Thank you. Treating how to use this in operating theater. So we have Andrea, Michael, and that's how people will see us. So that will be the patient here. Now I will open the 3D model, which I already prepared before. So that's what you will see. So the 3D view. And then you can choose save data. So here is my shoulder. I can put it anywhere. Here is the patient. I can move it around. I can put my planning. Want it's here. Wait for me. Leave it there. Come back and then give it to me again. It's here. Then I say, okay. Get it here. It's fixed. And I can start operating the way I want. Anytime with an accident, I can look at it. Ah, okay. To me. Around. Okay, I like it or I like it. Want to come back here. That's it. Okay, thank you. So guys, actually it's fun to welcome you in my living room in Switzerland. So we have Phyllis from Scotland, we have John from the United States, and we have Thomas Gregory from France. I see you waving, Thomas. That's great. John, hello. And we have a ball in the middle of the moon. So, thank you, Mohy. You're welcome. Thank you for coming, Thomas. فرصة سعيدة. مع السلامة. مع السلامة. مع السلامة. تصبحوا على خير. مع السلامة. إن شاء الله. مع السلامة.
Professor Mohy, you are with us, sir?
Yes, I am.
Yes, I think the connection is not very well for the videos, but if you please can enumerate to us what's meant by virtual reality and how it is being used in the shoulder surgery and the shoulder replacement. We have seen the video, we want to hear you, sir.
Sure. So the whole idea, there is a difference between virtual reality and mixed reality. The first version which we see is virtual reality, which you are totally virtual. You have virtual reality glasses and you wear them and you are in a different world than the current world. You know this, like also it's available for games. You can do games in there. You can see another world. You can diving. You can go like watching a movie inside a different world. And this is available also for training for orthopedic surgeons. There are some softwares where you can train operating skills, where you can train simulation of an operation inside that virtual reality classes. So this is one part of the virtual reality. The other, or the more advanced, or what we use now, we can apply to the surgery, is the called mixed reality. In a mixed reality, you can see both. So you can, part is the virtual, these holograms, where you can do the 3D reconstruction of the scapula of the patient, of the humerus, of the planning of your prosthesis. And what you can do is transform this or send it to your HoloLens or some other virtual mixed reality visualization glasses. And through this, you can take actually your planning, your X-rays, your MRIs, your CT with you every day. You are everywhere. You are independent of any infrastructure of the hospital. You have your preoperative planning with you. You are sterile, and still you can move your X-ray, your MRI, you can move your preoperative planning. You can show it to the others in the operating theater. So if you have any screen, computer screen, just simple connected with Microsoft Teams, and they can also view what you view. And this is the idea of mixed reality. And the HoloLens itself as apparatus, you can compare it to an iPhone or a smartphone. So what we have is difference between an analog mobile phone, like the old well-known Nokia 6210, and when the iPhone arrived. So what we used to do today is the 3D prints. So we have a plastic part, hard part, where you have to sterilize, take to the operating theater, then you cannot fix it to the position. So you have to hold it with one hand, and then you have to operate with the other hand. So it's hard. And the more advanced or the smart solution now is a mixed reality. One part of the mixed reality or the glasses is that you can view the preoperative planning. But the other things are the other options which I tried to show in the videos. So there are different possibilities. You have different apps. It's like a mobile phone, you download the apps, and through the apps you have more stuff to do. So Microsoft Mesh, that's which allows you to meet several persons through their avatars. You stay in a room, you can work together, you can talk together, you can manipulate the planning, you can work on one virtual hologram all together simultaneously at the same time. So we can do some meeting like what we are doing now to discuss difficult cases. You can discuss it with your residents. I can be here. My residence is in Switzerland. He has a difficult case. We can meet. We can discuss it together no matter where, if you have a good internet connection. That's you need.
Sir, I know that you are one of the most experienced surgeons in Switzerland and all over the world in mixed reality shoulder surgery and shoulder replacement. But I'm asking about the applicability of such a technique in all over the world. In Egypt, it is applicable for everyone?
This is the advantage. The main difference, what I do or what I used to do before moving to mixed reality is navigation. And navigation, as you said, it is limited, it is expensive. If you get robotic, it costs $2 million, all of that. And this is a good advantage actually of mixed reality, or why I'm very big fan of mixed reality, because you can actually wear it everywhere. You can use it in any country. You are independent of the infrastructure of the hospital, so you can go anywhere and you have your planning and use it. So all what you need is mixing like the HoloLens or something equivalent, and then the software to export your planning to a hologram. So one of the cases, it was on the video. This is like a real time, which I did 3 weeks ago. This is an 81-year female patient, which has massive osteoarthritis. She has been suffering already for 6 years. She didn't want to get operated on in the beginning, and we tried non-operative treatment, and then it becomes more advanced. It became more wear and tear of the glenoid, so it's very medialized. I don't know if we can start the video so you can see actually the CT builder.
Patient with osteoarthritis for the past 6 years, non-operatively treated. I decided to plan a bio-RSA 3D planning hologram for the bio-RSA. This is how it should look like. Here you see osteophytes at the front and at the back, which we'll have to remove intraoperatively. And take every part out of each other. So you can see the base plate. This is the extended one. You can see scapula and the graft. So this is the GPS navigation. That's actually what we have. So it's here. You can change this thing. That's how we plan that's exported. The navigation is fixed on the contralateral side of the patient using mixed reality. In addition to the navigation is the facultative laparocoid process is important, and our reference surgery navigation. It's a regular deltopectoral approach, and then external release, subdeltoid release, removing the bursa and any adhesions between the deltoid and the rest of the rotator cuff. This is an important step for the exposure of the humeral head. A Mayo scissor can be used and spread under the delta. A small part of the CA ligament can be released. The long biceps tendon can be identified in the bicipital groove. This is a good reference separating the greater tubercle from the tubercle minor. A biceps tendinosis or tenotomy could be done in this case with a lot of tendinopathy of the long and biceps tendon. I decided to go for tenotomy. As you can see, the bicipital sheath is also very thickened. After that, I identified by the three sisters at the lower border of the subscapularis, and I like it. I perform a tenotomy to the subscapularis, and then a small bridge is left for reattachment later. A capsular release is performed at the inferior part of the humeral head, also around any present osteophytes. The subscapular stem is tagged using 2O suture in the Maiden-Hallen technique. These sutures will be used for the reattachment of the tendon later. Internal release along the nerve to mobilize the subscapular tendon. Now the human head can be good visualized and exposed. The graft is prepared and harvested in situ according to the preoperative planning and hologram. A 5 millimeter graft is obtained after preparation of the humerus. The glenoid is exposed. If the foot retractor doesn't work well, you can use instead the bunny retractor, also known as a Playboy retractor. A Homan retractor superior and Pankart retractor anterior are usually helpful for the exposure. I use the Ranger for the soft tissue remover here because of the navigation. Be aware not to remove the osteophytes until the navigation part is done. After that, I perform the inferior release of the tricep, staying close to the bone to avoid any nerve injury. For the navigation, it is important to have a good exposure of the coracoid process, and having a Homan medially is helpful in this situation.
So here, as you see, for the navigation part, we still with the mixed reality, we are limited. We cannot navigate with the mixed reality. What you can do, you can pre-operatively plan. You can take your hologram with you. You can place your hologram beside the glenoid, and you can see and compare. Similar when you have a 3D printed glenoid with difficult cases. But we are working, I'm working with different companies developing solutions for the navigation using mixed reality. And I think we have been able to do it on cadavers. So the next step would be doing the studies for the release and the CA acceptance and getting accredited in Europe. So this will take us, I think, by the end of next year, we will be able to navigate through the mixed reality. at the moment, we have, for the navigation part, we need to use still
Sir, you are muted, sir. Dr. Mohy, you are muted.
Oh, sorry. So the good thing about the mixed reality, you can take it anywhere, and I can use it here. I can operate with it in Egypt. I can operate with it in Australia. I can operate with it anywhere. Problem, you cannot navigate with the mixed reality. So this is the current limitation of the HoloLens or any other product. So we are working closely with two companies to develop solutions for this. We have been able to do it in cadavers. So the next step will be applying for the CA accrediting in Europe and having by the end of next year a solution which can allow us to navigate using our HoloLens for mixed reality, which can allow us to skip the part of the navigation at all. And we don't need this GPS navigation anymore, hopefully soon. So in summary, you can combine both at the moment if you need to navigate your glenoid, but you can still use it as a 3D printer. So you have a 3D print just as a hologram. You can use it, you can play around, you can fix it, you can duplicate what you have planned without navigation. So this is the stand we have today. The next video will show how does the navigation actually work. This is not like the old-fashioned navigation where you have like 3 cameras everywhere around the operating theater. It's just this tablet and the camera is embedded on it. And you have the glenoid tracker, you have the one on the coracoid and one on your drill. So you can always real-time drill in the correct retroversion inclination. And accordingly, you are sure where your peg is gonna go inside. And you are very accurate. This is what we are still missing in the mixed reality part. But otherwise, you can do conferences, you can connect, you can discuss cases, you can plan together. You have a lot of options through the mixed reality HoloLens classes.
Sir, do you perform the mixed reality technique in every case, or you preserve it just for complicated and revision cases?
Navigate, I use them separately, so they are independent of each other. Mixed reality, I use with every case. Navigation, I only use in complicated, where I use allograft, bio-RSA, big retroversion of more than 15 degrees. These are the cases which I like to use navigation. But mixed reality is actually, all what you need for mixed reality is just a CT. So I do a CT anyway regularly before doing any procedures. So you have the CT DICOM pictures and then you export them. That's all what you need. So I do it for every case, the mixed reality part.
I hope, Dr. Taha, in your next vacation, after you spend part of it in the North Coast, I hope you will we will have a chance to visit us and do some cases in my university, so the junior surgeons will be accustomed to these marvelous techniques, sir.
Sure, I'll be more than happy, because actually you don't need a lot of infrastructure. Just get it with me and it's ready to go. So
thank you so much, sir.
You're welcome.
Thank you, sir. Thank you so much, sir. The videos are working, or Dr. Mohamed, the video is working?
If we have time, we can show you the last videos. It shows the navigation.
Yes, of course, sir. Of course, sir.
Sure.
The connection in the North Coast is not good.
No, it's very hard.
Yeah.
That's why I sent all of the videos before anything. But I can comment it if it's not.
Yes, please.
If the audio is not working, yeah.
Yes, please.
Sure. So what we see is the tracker. So this is the extra steps for the navigation. Before that, we show the very normal steps for the processes, and now you have a tracker, and this tracker has to be fixed to the coracoid process. So you have one small anterior screw, which you fix first, but don't tie too much. Then comes a long posterior screw. You can scroll it down, and this is for the fixation. And then you go again and re-tighten the anterior screw. Sometimes you need to tap on it. Don't tell the company, you're not allowed to officially, but I just tap it and it works better. You get more, it gets tighter, easier. And then after that, you put the glenoid tracker. Once you place it on it, there is a click, you feel it, and then you rotate to the correct position. After that, it stays stable. So you have to find the correct position, and then once it's stable, then you have your position. Then you can see on the right hand side is the screen, which I look at. On the left side is the operative place. So what you do is you start the acquisition. So you have to identify, the computer is going to tell you on the tablet, it tells you every single step. So the first step is to identify base of coracoid, then the anterior border of the coracoid, then the lower surface of the coracoid. And the navigation system did already import your planning and your CT. So, and that's how it can compare real time, okay, where is the position you are having now according to the CT. And then you go across the anterior border of the glenoid. Then you identify the 12, 3, 6, and 9 o'clock. After finishing that, you go through all of the glenoid surface. And many people ask about the HoloLens, if you can wear it, if you can wear it for 2 or 2.5 hours during the operation, you get used to it. Like when you start wearing eyeglasses at the beginning, you feel it, you notice it. After that, after 5 minutes, you just get used to it and you don't even notice that you are wearing the HoloLens. And after that, finishing the tracking, it gives you a green marking, which means, okay, steps are correct, you have been tracked. This was a challenging case because of the huge osteophytes anteriorly and posteriorly. So it was a challenge also for the navigation to find the correct entry point. And these are also the cases which I'm very thankful when I have my HoloLens and I have my hologram in front of me so I can real-time compare what the GPS is saying with my preoperative planning. Technique is great, but still you need to double check everything because it can also make errors with such big osteophytes. That's why also I said in the video, like it's important to remove only the soft tissue at the beginning and don't remove the osteophytes because your CT has the osteophytes in it. Same as PSI, patient-specific instrumentation, when you have these plastic guides, you also, they are all done on the CT, so you need to keep the osteophytes. This is an important step. It takes 2 to 3 minutes to do the calibration. But after that, you can see real time on the left side, that's my drill. And on the right side, there is a green dot, that's my entry point. And then for the inclination antiversion, you can see a circle, orange circle. And when the orange circle is aligned on that green dot, you are in the correct position. And then you can drill. From here on, it is as simple as any other steps for reverse shoulder prosthesis. You drill, you ream, and then we had a graft as well. And that's also one of the good advantages of the mixed reality because you can always view the preoperatively planned graft, how big it should be.
Dr. Taha, you are muted again. You are muted again.
Oh, thank you. You are hearing me now. So with the mixed reality, you can see the hologram, you can double check, and you can see the graft. You can cut it as you preoperative plan it. I use a Ranger to clear all of the osteophytes and the soft tissue. I find it's a good extension of my hand and finger, and I don't have to go deep in the tissues. That's the long peg with the graft on it. You go through it and you know, okay, that's a correct position which I planned. You tap, it's like, yeah, you have to be careful while tapping with these long pegs. You tap, wait a little bit, tap again, wait a little bit, as we learned it all from the hip prosthesis. When you do it without cement, all of this, you have to just wait for the bone to relax and readjust. I haven't seen, and that's after inserting the humeral components, and you can see intraoperative X-ray and postoperative X-ray of the patients.
Thank you so much, Professor Mohy from Zurich University, Switzerland, for this interesting, very interesting technique.
It's my pleasure. Thanks for inviting me.
Thank you so much, sir. Thank you. Any questions to Professor Taha? Okay, thank you so much, sir.
Thank you.
And thank you for joining us in your vacation.
No problem, it's my pleasure.
Thank you so much. Thank you so much, sir. Our next speaker will be Professor Magid Sami from Ain Shams University. Professor Magid.
Okay. Well, after listening to this very nice and high-tech presentation, I think we will come back to the ground and face some of the cases that we actually see here in Egypt and see how we can deal with them. And my topic is about locked shoulder dislocation. This case is a 30-year-old guy who is addicted to tramadol tablets. And he came with a neglected locked anterior shoulder dislocation for 1 month. Actually, we have seen a few of these cases, and these guys addicted to tramadol, they get seizures. And surprisingly, sometimes they get anterior dislocations rather than posterior dislocations. And the strange part is we can understand that sometimes posterior dislocations can be missed. But these guys have missed anterior dislocations, which mean that they do not even seek medical advice, because as we can see on the X-ray, you cannot miss that this is a dislocated shoulder, unlike a posterior dislocation, which can be sometimes deceiving. This is what we have. When we have an engaging Hill-Sachs which is left locked in the anterior dislocation, the strong hard bone of the anterior border edge of the glenoid keeps on impacting inside the humeral head. And therefore, we usually see huge Hill-Sachs defects. And any trial to do a forceful manipulation and more deepening of the Hill-Sachs defect up to splitting of the humeral head. So when you have a case like this, missed locked dislocation, do not attempt to do a closed reduction. Of course, these guys, since sometimes they don't really suffer from the pain due to their addiction, it seems that they try to rotate the shoulders, and therefore they get more deepening of the defect. So thinking about this, the real problem that we have is a huge Hill-Sachs defect. We know the concept of glenoid track. It's the width of the Hill-Sachs defect plus the attachment of the rotator cuff on one side, and 83% of the diameter of the glenoid in the maximum diameter part. If the width of the Hill-Sachs defect is more than the glenoid track, then we will have an off-track or engaging lesion, and they will keep on dislocating again. So what to do? How to make this glenoid track better? How to make an off-track lesion an on-track lesion? The logic approach having a large Hill-Sachs defect is to graft this defect, to decrease the size of the Hill-Sachs defect, since the pathology in these cases comes from the humeral part rather than from the glenoid, which is usually not affected. So it might seem logic to do grafting of the Hill-Sachs defect, whether with iliac graft, or we tried for some time to do Oates grafts from the knee to have some cartilage and increase the range, or to do a remplissage for this huge defect. This all seems logic, but what we will present here is a little bit of different approach to these cases. The idea is we have to do an open approach for these locked cases. You cannot do a closed reduction. You will end up by deepening the defect and splitting the head. So you start by the classic deltopectoral approach, and then the head is shifted medially, as we expect in an anterior dislocation. So once we open, the head is somewhere here medially. To expand our approach, we have to release the conjoint tendon. So either you release the conjoint tendon and then you reattach again after the end of the procedure, or you do, and then of course you can face the possibility that it will not heal and it will be pulled down. So it's better to do a bony osteotomy of the coracoid with the conjoint tendon and then fix back to the coracoid. What we thought is, because anyway we are going to do a coracoid osteotomy to enlarge our approach, why not do a latter J for these cases? It's not a classic latter J because we will not apply through a subscapularis split. It's more like a bony augmentation of the glenoid, but that's what we want. We will attack this off-track lesion, not by decreasing the size of the lesion, but by increasing the size of the glenoid track. So even though the defect will remain the same, but the glenoid track will be much longer, so this off-track lesion will now become on track. Once we have done the osteotomy of the coracoid, and we do it as large as we can, we do it exactly just anterior to the attachment of the CC ligaments. So it's at the junction between the horizontal and the vertical part of the coracoid, to take the largest possible part of the coracoid. We then release the subscapularis, take it with tension suture, take it with sutures so that we will attach by the end of the procedure. And then we unlock our lock dislocation. Of course, if you try to do any form of internal rotation, you will deepen the defect. So first of all, you have to start by pulling the humeral head in an anterolateral direction to unlock this locked dislocation. It has to be unlocked first before trying to do any rotation. And do not try to insinuate any Hohmann retractors or any periosteal elevators between the glenoid and the head, thinking that you can lever the head out, because again, you will end up by deepening the defect or even splitting the head. Once we have unlocked the dislocation, we can rotate the head and we can see the huge size of the Hill-Sachs defect. It might seem logic to graft it, but we chose to go for another approach, as we mentioned, since anyway we have done the coracoid osteotomy. One of the things that we have noticed is that once we try to locate them back, they keep on jumping anteriorly. And this is because, unlike we might expect, the posterior capsule is tight. We think that once we have a locked anterior dislocation, theoretically the posterior capsule is stretched. That's not the case, it's tight. So once you have unlocked the dislocation with the electrocautery, we go and we release the posterior capsule so we have enough space that the humeral head would rest posteriorly and will not be pushed anteriorly because of the long duration. The soft tissues got adapted to this locked anterior dislocation. Once we reposition it back in place, we increase the glenoid arc by the coracoid process. Of course, this is not a classic lateral J because, as we said, we are only elongating the glenoid arc. So this is what we do. We fixed the large coracoid piece to the glenoid, increasing the size of the glenoid arc. The Hill-Sachs defect is there, but as we rotate, it's no longer engaging. It's on track because we have elongated the glenoid track. Since it's an open procedure, you can add an open remplissage. With rotation, we can easily see the defect. You can put your anchors here, and then as you put it back, you pull the sutures through the infraspinatus and you suture it. So you can add an open remplissage if you choose, but we did not think that this is necessary, and we wanted to see the results with this technique. This is how it looks. So this is an off-track engaged Hill-Sachs, and this is how it looks by the end of the procedure. The Hill-Sachs is there, but even with maximum external rotation, it will not engage on the glenoid. It will remain on track because we have elongated the glenoid track. We published this technique, having done it on 6 patients, and we have not had redislocations in any of these 6 patients. Of course, this is a small number of patients, but locked, neglected anterior dislocation is not a common entity. So this is one way of facing humeral head defects by neglecting the defect and working on the glenoid track by elongating the glenoid track. The other approach is to work on the Hill-Sachs defect or on the humeral head defect in general, either by bone graft or by doing a muscle transfer or muscle tenodesis. And this is what we do for locked posterior dislocation. This is a case with a locked posterior shoulder dislocation, which was neglected for 3 weeks. You can see the overlap here, and you can see the dislocation, the locked dislocation, and the reverse Hill-Sachs defect on the MRI. We have to suspect the posterior shoulder dislocations. If you see this really internally rotated humeral head, which is different in shape from the normal AP, I will show this. You have to suspect shoulder dislocation with certain traumas, with seizures, convulsions, and with electric shocks. And it should not be painful, even in an acute trauma setting, to do a passive external rotation of the adducted shoulder. So if you do a passive external rotation of the adducted shoulder, of course, this is under anesthesia, but you do it as you examine the patient, and it's completely locked, there is no external rotation, then you have to suspect that this is a locked posterior dislocation, and in this diagnosis. So please, if you suspect it on the X-ray, you have to examine the patient by passive external rotation in adduction. If it's locked, he cannot go beyond the neutral position, then you have to go for external image. This is what we call the light bulb sign. This is how it looks when it's completely internal rotated in the locked posterior dislocation. And this is quite different from the normal AP. This is not an AP of the shoulder in the anatomic scapular planes because we cannot see the joint line, but even though, and the light bulb with the internal rotation. If you have this suspicious X-ray with the locked shoulder not going to external rotation passively in adduction, which, as I said, is not a painful position even in the acute trauma setting, then you have to suspect a locked posterior shoulder dislocation, because 40 to 60% of these cases are missed because they come in a sling. So you expect with the sling that it's normal to look internally rotated because he's in a sling. The sling puts the shoulder automatically in internal rotation. You try to move it, you think it's painful, so I will not try to push it into rotation, and they get missed. So in the imaging, additional X-rays should be done. The Y scapular view the axillary view, of course, is not applicable in the acute trauma setting. It's too painful. You cannot put the arm in this type of abduction. So we can go for the bumped up, or what we call the trauma axillary view, or the Velpo view, where he leans backwards and you can have the X-ray. Once you suspect, it's very important to do a CT, because the CT will confirm the diagnosis, and you can measure your reverse Hill-Sachs, because you can go for grafting if this is 20 to 45% of the humeral head. If more than this, this is a completely destroyed humeral head, and you might think of replacement. So this case presented to me, and surprisingly, he presented with the MRI because he had shoulder pain. It was not diagnosed, and they asked for an MRI to see what is the reason of the shoulder pain, and the MRI said it's a log posterior dislocation. So waiting for the MRI to diagnose a posterior shoulder dislocation, because we have no idea why he's still in pain after 2 or 3 weeks, means that no one cared to examine the passive external rotation in abduction. Of course, you can see the locked posterior dislocation with the reverse Hill-Sachs, and you can see the humeral head in these posterior cuts where the glenoid is not seen because it's posterior to the glenoid. We do a standard deltopectoral approach, but in these cases, we prefer to do the modified McLaughlin. We go for attacking the reversed Hill-Sachs, because you cannot really do a large bone graft on the posterior aspect. It will be too annoying for the patient. It will raise the infraspinatus. You cannot put large bone grafts on the posterior glenoid aspect. And second, we want to do the relocation from an anterior approach, and we don't want to do a mixed anterior and posterior approach. So you can do the whole work from the anterior approach. And in these cases, we will work on the defect, the humeral head defect, to fill this defect, and therefore, again, this off-track lesion will become on-track. What we do is we do a lesser tuberosity osteotomy. And since we have a large defect, we prefer to do the osteotomy just medial to the bicipital groove. So we locate the bicipital groove, and we start our osteotomy just medial to the bicipital groove to get as large piece of bone as we can get. So we do the osteotomy, and we get a really large piece of bone, the lesser tuberosity, with the attached subscapularis. Of course, we know that the original McLaughlin procedure described some 70 years ago in 1952. He only did a soft tissue tenodesis of the remplissage, but in a reverse Hill-Sachs lesion, and done 70 years ago. But this had a high redislocation rate. So filling with the bone graft from the lesser tuberosity together with the subscapularis yielded more satisfactory results. Again, you have to unlock the dislocation and do not try to force the humerus into external rotation. You will end up by deepening the defect and splitting the humeral head. So you have to push the humeral head posteriorly and laterally first to unlock it before doing the external rotation. Once you do this, you can see the size of the Hill-Sachs defect, and you can put the lesser tuberosity with the subscapularis and fixed by screws, and then you test. In maximum internal rotation, there is no locking, it's not catching on the edge of the glenoid. If this is the case, then you do not need to use any special slings or shoulder holders that would keep the hand in neutral or external rotation. He can use a normal sling even in maximum internal rotation because it does not lock in internal rotation. And this is how it looks on the X-ray. Sometimes the defect is too large, or your osteotomy is not that big that you need, even with the lesser tuberosity, to add bone graft from the lesser tuberosity, and with the screws, you add sutures. Either you can put anchors and fix by the sutures of the anchor, or you can do transosseous suturing. And this is how it looks. If you fear that there is a small piece of the defect left that may engage on the posterior rim of the glenoid, then you have to support the shoulder in neutral rotation for 6 weeks and not allow it to fall into internal rotation. And this is how it looks on the post-operative X-ray and CT. And this is the 1-year post-operative range of motion for a patient with neglected locked posterior shoulder dislocation. So the take-home message is that engaging or off-track head defects, whether Hill sacks in anterior dislocations or reverse Hill sacks in posterior dislocations, can be rendered on-track, non-engaging, either by grafting the defect with bone graft or by rendering the defect extra-articular through filling it by muscle, whether infraspinatus stenodesis for Hill sacks or subscapularis stenodesis for reverse Hill sacks. Or you can neglect the head defect and work on the glenoid, elongating its arc so that this off-track lesion will be changed to an on-track lesion, which we apt to use for the neglected anterior dislocations. Thank you.
Thank you so much, Professor Maged Sami and Shamsi University, for this very interesting talk. If we have any questions to Professor Maged?
Professor Maged, good evening.
Good evening.
Do you think that we can do some treatment of this locked posterior dislocation only using arthroscopy view, to do like McLaughlin stuff using arthroscopy, or you prefer to do it open always?
Difficult to do a closed relocation of the joint. And once I'm going to go for an open reduction, I will have to do what I just described. If it's just presenting and you can do a simple closed relocation of the joint, of course you can do an arthroscopic subscapularis stenodesis. Okay, thanks.
Thanks a lot. Thank you.
Thank you so much, Professor Maged. Now we will move to the next speaker. The next speaker is my dear friend, Professor Mauricio Raffaelli from Nayon Institute, Brazil. You're very welcome, Professor Raffaelli.
Hello, everyone. Just a minute, I just want to, I have some troubles here to show my screen. Just a second.
Take your time, sir.
I normally don't use this computer. This is my office computer. Normally I use my home computer. Let's see if I can share my screen now. Just a second. Now, I think I can do that.
Yes. Yes.
Can you see my screen?
Yes, sir.
Yes, perfect. I just want to say, Dr. Mohamed, it's an honor to me to be part of this incredible meeting. It's fantastic to see Dr. Imam presentation, Dr. Magnet's presentation, and Dr. Mohy Taha is the name here in the shoulder disease to do the planning and the 3D reconstruction and using this type of future stuffs to teach us. Here in Brazil, we have Dr. Bruno Gobato. He works with Dr. Taha. And it's good to see that the reality, the 3D reality, will be the reality for us in a short time. I will talk about the massive rotator cuff tear. Dr. Imam just told a lot of the rotator cuff, so I go directly to the massive rotator cuff stuffs. This is my group that I make part from Brazil. Our leader is Dr. José Carlos Garcia Jr. from São Paulo, Brazil, the Nayon Institute. No disclaimer. And for me, the first part is to understand and to define what is the massive rotator cuff tear. Because when you look for the literature, someone will say about 2 tendons with a lesion more than 4 centimeters. Another stuff said 1 tendon with more than 4 centimeters. Another paper said for us, you need to have the great tuberosity exposed. So I found this paper that tried to determine the definition of the massive rotator cuff tear. So in this study, the tendon retraction should be in the glenoid hem, and the tear should expose the great tuberosity more than 67%. So we have the supraspinatus and big part of the infraspinatus big lesion to define a massive rotator cuff tear. Another way that you do that is to use the arthroscopy to try to understand and to measure this tear. And this paper from Dr. Lederman showed for us there is one big difficulty to create some algorithm to treat all the massive rotator cuff tear, because there is some patient factors, there is another associated pathologies, and the personal experience and the data that our doctor that we have interfere in our experience to treat this lesion. So what you need to do for a very good cuff repair planning. So we have some steps. The first is identification of the lesion. The second part is to understand the mobility from the tendon. The bone preparation of the footprint and the quality of this bone is very important. And you should do a steady, a tension-free, and try to do anatomic tendon fixation. If you do these 4 steps, you are very close to have a healing tendon. So to do that, I think us, the shoulder surgeons, need to know a lot of things. The first part is to know the cuff anatomy. We need to know the function. We need to know the innervation. You need to know the tension, the vascularity, and the footprint of this tendon. Because if you try to do it anatomically, you need to recover the position of the rotator cuff. Another stuff that we need to know is different ways to repair the cuff, because I really think the repair from the rotator cuff don't exist a menu to do that. We need to individualize each repair. And to individualize each repair, we need to know different ways to use that. Anchors, not anchors, and knotless anchors, single row repair, double row repair. We need to understand and to try to do the best for the patient. And you must know the different way to repair and the different evolution for each repair that you know. In this paper, in this study, showing for us that the transosseous equivalent is a little bit better in contact tendon when you compare to other ways to do the repair. So if you can recover anatomically the tendon, I think the transosseous equivalent way using anchors is a good fixation to treat these lesions. Another thing is you need to individualize the cuff repair. So each patient has a type of lesion and a bad tissue that you need to try to understand to fix that. In this study, Dr. Imam just told for us the double row repair and the single row repair has had good evolution when you compare the repair of this way to fix. But in lesions more than 3 centimeters or 30 millimeters, the double row technique is recommended to repair because it has a lower repair rate. You need to know your patient injury. You need to understand, is this cuff repairable or not? So Dr. Gartzman in this paper, 1996, creates some parameters using the tear size measure, the tendon quality, the tendon mobility, and the suture rate replacement to evaluate if you can repair or not this massive rotator cuff tear. But since a lot of things evolved, so us understand a little bit more the pathology of the rotator cuff, and Dr. Pascal Bolo and Dr. Gilles Walsh made this study in 2008 to understand the criteria to repair this tendon. So if you have a substantial retraction tendon with bad quality from the tendon and from the bone, It's difficult to repair these tears. Advanced rotator cuff muscular atrophy, Guttalier stage 3 or stage 4, when the muscle has more fat tissue than muscle tissue, is very, very difficult to fix the massive tears. And the proximal urus migration with an acromial-humeral interval less than 7 millimeters showed for us a difficult place to put the anchors and to recover this interval. And you must know your patient. You need to understand what's the patient expectation, what you want with this surgery. We need to have less pain. We need to recover the range of motion and the strength of your arm, or you just need to have a good life. We need to understand the associated disease, diabetes, has some bad healing results in the rotator cuff repair. And another thing is very important if you have a smoke patient. The smoke patient have some vascular alterations that can affect the healing. So improve the failure of this arthroscopy. And for me, the doctor needs to do two things with your patient. The first is explain the injury. Your patient must know the good and the bad results and some solutions for the good and for the bad results that you can do. And you need to always do your best, because the massive rotator cuff tear is very, very difficult to improve the quality of your repair. So I bring here two clinical cases of my practice to try to understand when you can recover the anatomically this tendon, and another that we can't recover the anatomic seat of the rotator cuff. This is a patient, male, 54 years old, lawyer, just practiced walking, right shoulder pain for 4 years, with progressive worsening for 1 month after fall. So his patient just have some pain in the shoulder, but he fell down and improved the pain and improve the loss of range of motion. This orthopedic physical examination, the NEAR test was positive, the Hawking-Kennedy test was positive, the Job test is positive with loss of resistance in elevation when you compare with the lateral size, Palmer test negative, Gerber test negative, Bierhug test negative, the infraspinatus test was positive, and the drop arm is negative. So the patient had some pathology in the supraspinatus, in the infraspinatus, but not a huge posterior lesion of the rotator cuff. With this examination, I think that the teres minor and part of the infraspinatus maintain attached to the bone. The patient has normal range of motion, but in active movement presents 75 degrees of elevation. And this is the exams of this patient. So you can see a big supraspinatus there, some fat infiltration from the supraspinatus. The part of infraspinatus is very bad to see in this cut, and the X-ray was normal. And this is what I did. This is looking for the subacromial space. My portal is posterior lateral. Now I'm clean the bursa. You can see the glenoid. This lesion is very, very big. I try to clean all the bursa to understand. Looking at the infraspinatus, the lower part of the infraspinatus maintain attached to the bone. So we have the upper part of. So we have the upper part of the infraspinatus and the supraspinatus lesion. Now using a grasper, try to understand the form of this lesion and the mobility of this tendon. So I can reduce the lesion in the anatomic way, and I will try to do a best repair for this patient. I want to try a double row repair. In the first time, I will pass a tendon to tendon suture, fix this upper part of the infraspinatus together with the lower part of the infraspinatus, and this repair, this suture, just fix a very good part of the posterior lesion and reduce the size of the supraspinatus tear too. When I tight this knot, the lesion from supraspinatus become a little bit smaller, and using a grasper, I try to understand if I can reduce this anatomically. And look at that, yes, I can do that anatomically. So I go for a double row fixation. I really like to prepare the bone to attach this tendon. I really think that the blood that comes to this place is important to heal this tendon. Using medial anchors quite near to the cartilage site. This is the first anchor. This is an anteromedial anchor. I like to pass the suture, one suture, a simple suture, and other suture in a mattress way. And then I put another posterior anchor, and then I will put a knotless anchor in the lateral part of the great tuberosity to complete the transosseous equivalent way to fix that. This is a knotless anchor for footprint for Smith & Nephew, and it's good to fix, to attach, and the tension. We can tension this tendon a lot to maintain the position. So if you have a massive rotator cuff tear, but the tendon has mobility, and you can reduce this anatomically, this is the way that I think is the better to fix this kind of tendon. A double row repair with transosseous equivalent using medial knot anchors and lateral knotless anchors to do that. And that's another case, a patient a little bit more younger than the first, is only 49 years old, male, a company manager, no physical activity, fell down 3 years ago with trauma in the right shoulder, a progressive pain in these 3 years of trauma. And now we have a lot of pain during the night, during sleep, and a progressive pain during daily activities. The physical examination is quite near to the other patient, but this patient has a little bit better activity motion in elevation, 100 degrees. And this is the X-ray from this patient, and this is the MRI from this patient. Look that. There is a big supraspinatus lesion. The supraspinatus and the infraspinatus is completely detached from the bone. The subscapularis is very good, and lower part of the infraspinatus looking good too. You can see that. Some atrophy in the supraspinatus, a Gutalier grau 2 to grau 3. The upper part of the infraspinatus is bad, but the lower part is good. The teres minor is good too, and the subscapular is very good. So in young patient with this massive lesion, I always try to do an arthroscopy to understand this lesion and try to fix it. If I can do that, I think the transfer tendon is a very good option for this case. So this is the treatment. The lesion of this patient is a huge lesion from massive rotator cuff. Look that the biceps is exposed. Only the lower part of the infraspinatus is attached. I go inside the lesion. The upper part is very big lesion. So with a grasper, I try to understand the mobility of this tendon. And look that I can't put this tendon in the anatomic way. I can do that. If I put in the anatomic great tuberosity part, I will create a very tension tendon, and I don't want to do that. Now I'm using an instrument. I'm cleaning the bursa in the upper part of the rotator cuff, going to the lateral portal, and now going to the posterior portal to make free the supraspinatus and the infraspinatus to improve the mobility of the tendon. After cleaning the upper part, look for the infraspinatus go a little bit better to the great tuberosity. But when I test the supraspinatus, this lesion is still a tension to go to the great tuberosity. Look that I can't put the great tuberosity. Now I open the rotator cuff interval to improve the supraspinatus mobility. You need to do your best. You need to do everything you can do for this patient. And now I test, and the supraspinatus come a little bit better. But I can't reduce that in the anatomic size. So I go to repair a medialization repair, and I would like to use the long head of the biceps like a reinforce of this repair. Now I'm opening the biceps groove, and I'm testing to put the long head of the biceps a little bit posterior in the center of the great tuberosity to create just like a ligament in the upper part of the articulation and improve, reinforce the fixation of the rotator cuff. I made a bone footprint, prepared the footprint, and now I'm passing 2 sutures in a loop way to use. In this case, I only have knotless anchors, so I use a knotless anchor to fix the long head of the biceps. The middle of the great tuberosity to create this upper ligament. This fixation of the long head of the biceps, the tenodesis of long head of the biceps is good when you use this looping. And this is the position of the new position of the biceps. Now, using the same sutures that I passed through the biceps, I will pass through the anterior part of the supraspinatus in a Mason-Allen way, a mattress suture with a regular one. This I use to improve the fixation of the rotator cuff and to mobilize to pass the other sutures. In this case, I can't do a double row repair because if I do that, I will improve the fixation will be too strong, and the tension of this repair will fail the repair. Now I'm trying to do a medial row, a single row using a speed fix ripstop way, using a mattress sutures and a loop suture, and fix the first anchor in the posterior part of the supraspinatus and anterior part of the infraspinatus. And then I use another anchor in the lower part of the infraspinatus in the same way, speed fix ripstop fixation. This kind of fixation, this is the end of the fixation after suture the knots of anterior part, and I can recover the humeral head without tension from this rotator cuff. So I believe that this way of fixation is good in some cases. It's a try to do this repair, and the patient was very good. So the medialization of the rotator cuff, it's good. Can you do that? In this study from 2018, showing that if you medialize 1 centimeter, you don't have a lot of trouble about that. You can maintain the force and maintain the mobility of this shoulder. Can we try, or it's good to try a primary repair from this massive rotator cuff? This study from 2020 showed for us that yes, you need to try because you can do the fixation. If you can do a complete or a partial fixation, a partial repair, you can improve the pain and the function of this patient. But you must talk with the patient that you have higher rates of repair in this case of lesion. This is a study that showed for us, showed for you the technique that I use to posterize the long head of the biceps to create a reinforce, just like a ligament in the upper part of the shoulder, make the function like a capsular reconstruction, and you can medialize the suture and you improve this fixation, and the results was very good. This is another study from 2021. It's a recent one, it's June, last June, showing the same way, open the groove or the long head of the biceps and medialize him to fix the rotator cuff with very good results too. So for me, you must do your best. You must understand the lesion and you must talk with the patient, the good and the bad results. Thanks a lot.
Thank you so much, my dear friend, Dr. Raffaelli, for this very interesting talk. Thank you so much, sir. We have questions to Dr. Raffaelli.
Thank you, Dr. Raffaelli, for the lovely talk. You made the complex topic looks easy. And one question, when will you consider augmenting? Do you do augmenting massive tears? I totally agree with the double row, and the evidence is very solid in that regard. But when would you consider doing augmentation? Or is there any indication in your mind?
I think the augmentation is part of the future of the treatment of the rotator cuff, the massive rotator cuff tear, because you can improve the quality of your repair. Here in Brazil, we have a lot of problems because we don't have this patch to do the augmentation. We still not have. Smith & Nephew is trying to bring here to Brazil the Regeneten patch to use that, just like you showed for us. I really think that when I have this patch, I will use that. I will do the double row repair using this patch in the upper part of the rotator cuff to improve, to create some biology to improve my my fixation. And if you can do medialization of the tendon, I can use the patch to create in the upper part of the rotator cuff, fixing the patch in the rotator cuff and in the bone to create a repair just like a normal site of the rotator cuff. I really agree with you. The patch is a reality. The patch is good, but unfortunately, I don't have it in Brazil yet. I only use that in USA when I perform my course over there, but here in Brazil, we still not have it.
Thank you very much for the lovely talk.
Thank you so much, Dr. Raffaelli. It's an honor to join us tonight.
You are muted.
No.
Dr. Mohamed is muted.
Thank you. First, I would like to express my deep thanks about this wonderful talk. And my question is about using the long head of biceps. After you fix the long head of biceps and the greater tuberosity, would you like to tentomize the remaining part to decrease the pain, or you don't do this?
I learned this technique with Dr. Larry Field from USA. That's when I saw that a couple of years ago. That's my question too. This patient will have pain in the long head of the biceps because you do another tenodesis and it's improved the force in this tenodesis. And he talked with me that we don't need to cut the tendon. You only need to fix it. In my first case, I do double fixation for the longer head of the biceps, a little bit lower to the great tuberosity, and in the upper part to create this ligament. And then I cut in the middle. The patient don't have pain. And then I start to do only one fixation in the great tuberosity, and believe me, the patient don't have pain, because when you fix this tendon, you have a good fixation, you transfer this fixation in the tenodesis so that the tension don't go interarticular in the size that you create a new ligament. So you have 2 points of fixation, bone fixation, you create a new ligament. The tension go only for the lateral part of the biceps, and you don't have more the killer angle. You have a biceps only straight, so the patient don't have pain. I don't cut the biceps.
Thank you.
Thank you so much, sir. Our next speaker will be Professor Mohamed Salah Sharaf from Benha University, speaking from Saudi Arabia. Dr. Mohamed, you are ready?
Yes, please. Okay, I'm very proud to talk and to share in this wonderful course. And after these talks from Dr. Imam, from Dr. Taha, from Dr. Raffaelli, we will talk about these talks were directed to specialized shoulder surgeon, actually. So I will take a small light subject directed mainly to our junior colleagues. We will talk today about proximal humeral fractures. When I was during my residency program, we used to manage all these fractures and most of shoulder problems by just a sling. And reviewing the recent literature, now there is a trend back to the sling again, and there is a lot of news and a lot of studies showing that there is the surgery is no better than a simple sling for displaced fracture of the proximal humerus. So the objective of this talk is to overview the proximal humerus fracture instance, classification, treatment options, and spotlight on decision-making and management of proximal humeral fractures, and have some overview over the evidence-based outcome of fixation and arthroplasty following proximal humeral fractures. The proximal humeral fracture represents the third most frequent fracture in elderly patients after distal radius and fracture around the hips. There is a female to male ratio about 3:1. Reviewing the anatomy of the proximal humerus, we all know that the proximal humerus is composed of a head covered by articular cartilage, greater lesser tuberosity. The anatomic neck is this region below the humeral articular surface. Surgical neck is the region below the tuberosities. There is an inclination of the humeral head relative to the shaft for an average of 130 degrees and a retroversion of about 20 degrees. These are the four main parts as described by Codman. This is the articular surface. It has no attachment. This is the lesser tuberosity. It's attached to the subscapularis, and the forces acting on this is displacing it medially. This is the greater tuberosity attached to the rotator cuff, usually displaced posteriorly and superiorly, and the shaft part is usually displaced superiorly and medially by the pec major. Regarding the main vascular arterial supply of the humeral head, it arises from the anterior humeral circumflex artery, and that give rise to ascending branch and an arcuate artery, which is an end artery. Because of the close proximity of these vessels to the surgical neck of the humerus, there is high risk of avascular necrosis after these complex fractures. This is the mechanism of injury. For older patients, it's bimodal. For older patients, it's usually low energy falls from standing, and for young patients, usually high energy trauma may be associated with dislocations. As regards classification, we still most shoulder surgeons still use Neer classification, popularized in 1970. Is based on Codman 4 parts fragments. It includes 16 variants, all fractures with displacement less than 1 centimeter, with the exception of greater tuberosity 5 millimeter, and an angulation of below 45 degrees are classified together as group 1, which is minimally displaced fracture. Then the other groups are determined by the number of fracture fragments involved with a combination. As you can see, this is 2-part fracture. It can be surgical neck fracture. It can be greater lesser tuberosity, 3-part fracture, 4-part fracture. Each of these could be associated with dislocation, either anterior or posterior. This is the AO classification, less commonly used. Type A is an extra-articular unifocal fracture. Type B is a bifocal extra-articular fracture, and type C is an articular fracture and fracture dislocation. Clinical evaluation, there is usually a swelling and pain. Sometimes there is no swelling, and ecchymosis appear in the elbow region after a few days. Neurovascular evaluation is very important because of the very commonly affected axillary nerve injury. In these cases, up to 50 or 56%, according to some studies. X-rays, you should, as usual, take at least 2 views perpendicular to each other, AB view and the scapular plane, and Y scapular view. Of course, this axillary view is very difficult in acute trauma settings, so Velbo view is used instead. CT scan is very helpful in evaluating the degree of fracture displacement, especially in greater tuberosity fracture, and evaluating affection of the head, either head splits or impression fracture of the head, and degree and the size of the split, and to evaluate associated glenoid lesions, which may occur in these, especially in old osteoporotic patients. This is a very interesting and very famous study published by Hertel et al. It predicts the head ischemia after fracture of proximal humerus. They have done a prospective study, included 100 consecutive fractures. they assist the humeral head perfusion intraoperatively after pair holing, and in the whole number of patients, and they used a laser Doppler flowmetry in 46 patients. They found that the predictors of the avascular necrosis are the first and most relevant predictor was the metaphyseal head extension less than 8 millimeter. This is the metaphyseal extension part of the head. If it is less than 8 millimeters, so there is high risk of AVN. The other predictor is loss of integrity of the medial hinge, and the last one is the fracture pattern with the affection of the anatomical neck increase the risk of avascular necrosis and ischemia, and with the more complex fractures and displacement of fragment, the risk increase. Combining all these factors together increase the risk of AVN to up to 98%. So regarding the treatment options, it's either conservative or surgical. Surgical include fixation. Can use different tools of fixation, from heavy sutures to wires, either percutaneous. Intramedullary nails are used, and the most commonly used fixation is the locked plates. Arthroplasty is another option, surgical option for management of complex proximal humeral fracture, especially in elderly or with affection of the head. Regarding factors affecting decision making, we should look to patient factors. Patient age is very important in decision making. Functional demand of the patient, hand dominance, and associated comorbidities. Other factors are related to the fracture, include fracture type, classification, and local bone quality and osteoporosis at the fracture site. The other are the facilities and surgical skills of the treating physician and institution. So what are the indication for conservative treatment? The first indication is minimally displaced type 1 near fracture. The other indication is two-part fracture that are displaced less than 1 centimeter or could be reduced to an acceptable position. The last indication for conservative treatment is valgus impacted 3- and 4-part fractures in an elderly patient. Methods of conservative treatment are usually sling for 2, maximum 3 weeks, followed by progressive rehabilitation to decrease the stiffness and to improve the outcome. Hanging cast was used in the past, but recent studies show that it offers no advantage than sling, and it may result in non-union. So when to consider fixation? If displaced greater tuberosity fracture more than 5 millimeters, you can measure it accurately on the CT, axial view, or if you have a lesser tuberosity fracture with involvement of part of the head, or if you have displaced unstable surgical neck fracture or 3- or 4-part fractures. Surgical options include, as we told before, the percutaneous pinning. This is it has a very limited role actually. It's ideal for 2- and 3-part fractures where a close reduction can be obtained, but required additional fixation to allow early mobilization, and in some valgus impacted 4-part fractures in elderly. However, there is some rules. It should be patient must have good bone stock to ensure secure fixation. Displaced greater tuberosity fragment should be large enough, and the intact medial calcar region is very important for stability. So in this technique, we use 2 to 3 retrograde bends placed from the shaft to the head, and 1 or 2 screws or wires placed from the greater tuberosity. Classically, these wires should be serrated to avoid migration, either intra-articular or in the chest. And there is high possibility of injury of the axillary nerve if you didn't put the lateral wires far away from the greater tuberosity, and if you didn't take care about this medial wire. Complications: risk of injury of axillary nerve with lateral bends, long head of biceps with the anterior bends, loss of reduction, and possible bend migration. That's why a lot of linkage devices are used to prevent migration of these wires. Fixation, we used usually the deltopectoral approach, but we can use transdeltoid approach. Usually these buttress plates are not used today. What we are using now are these locked plates with the advantage of fixed angle plates. It has good head fixation, adequate number of screws in the head. It has holes for suture fixation of the tuberosities, which is the most important part of the fixation. The technique include taking the tuberosities, the greater and lesser tuberosities with heavy non-absorbable suture materials, and then you reduce the head fragment and restore the medial calcar. You can use bone graft, either strut graft or allograft. If you have a defect here, then you close the tuberosities together, and of course you can use some percutaneous wires to maintain temporary fixation until you put the blade just lateral to the biceptal groove. As we see, the blade is not a reduction tool in this maneuver. You have to reduce first, then you can fix. This is a 4-part fracture fixed with Phylus place, and you can see here the holes of the transosseous sutures that are secured to the plate. Restoration of the medial calcar support and the inferior calcar screw is very important to avoid loss of reduction. So in this case, it's better to put an inferior calcar screw here to maintain the reduction and to avoid varus mal positioning. This is a MIBO technique. We can use the plate here as a reduction tool in some cases of valgus impacted fracture where the medial calcar can be restored. Nails are not used frequently, usually used in 2-part fracture in a little younger patients. However, it has complication of violating the cuff and it is less stable, especially in rotational forces. Complication of plate include screw cut out and penetration, and this is very, very common complication of plates. And this is usually occur with varus collapse and avascular necrosis. If you can see in both cases, there is no inferior calcar screw and there is no restoration of the medial calcar. And this is the main cause of varus collapse and failure of Phylus plates. This is a very nice study, a long-term observational study that conducted to analyze the incidence of complications and revision surgeries after locked plate. They have included 788 patients, and the results show that there is decreased complication rate in the last 5 years. Complications used to be about 50%, 14 to 15%. It's now about 5% only. And they analyze the result and conclude that these decrease in complication are due to the use of reverse shoulder arthroplasty in complex cases that was misused by plates before, and by using the calcar screw and adequate technique for plating. This is another study to show the importance of inferior calcar screw and restoring the medial calcar to prevent varus collapse. And in this study, the most common causes of failure are loss of frustration, lack of frustration of the calcar, loss of inferior calcar screw, and cross-threading of the screws. If you can see the screws here, it's loose, not locked into the plate. So when to consider arthroplasty? Usually consider arthroplasty in non-reconstructible articular surface fracture, head split fractures, complex 4-part fracture in relatively young and middle-aged patients, and in severely displaced 3- and 4-part fractures with loss of medial hinge and osteoporosis. Of course, we used to use fracture hemi arthroplasty. It results in good bone relief, pain relief, but unfortunately, it has limited function. Restoring the humeral height is very tricky and very important in these cases, and restoring the tuberosities and fixing the tuberosities either together and or to the shaft is very important predictable factor for a good outcome. The increased trend now are to use a reverse shoulder arthroplasty in complex fractures, especially in elderly patients over 65 or 70 years old. And there is a lot of studies suggesting a better outcome of reverse over the hemiarthroplasty. This is a very recent randomized controlled study, multicentric, that find that there is a better result of reverse shoulder arthroplasty over fracture hemi. So if you are going to use a reverse shoulder, should we use it acutely after fracture, or should we give the patient some time to be managed conservatively? This is a systematic review and meta-analysis included 16 studies, which comprise 322 patients undergoing reverse total shoulder for a fracture sequelae. They conclude that there is no difference in forward deflection, clinical outcome scores, and reoperation rate, either to use between both groups, the group who used acute and the delayed reverse shoulder. So they conclude that given the risk associated with surgery in the elderly population, consideration may be given to initial trial of non-operative treatment in this patient, saving reverse total shoulder arthroplasty for those in whom non-operative treatment fail without compromising the ultimate outcome. However, another large study included 4,245 patients with acute reverse shoulder arthroplasty and around 1,000 in delayed primary arthroplasty identified in the US insurance database between 2005 and 2014, so that delayed primary reverse was associated with higher short-term 1-year rate of revision and dislocation compared to acute primary. So, does the surgery yield a better result than conservative treatment? There is a lot of studies that show that there is no difference between surgical and non-surgical treatment of displaced fracture proximal humerus. This is a very important multi-center randomized controlled trial. They recruited 250 patients with a mean age of 66 years, and patients were randomized into either operative management, either fixation or arthroplasty, and conservative treatment. And at 3 years follow-up, they find no difference in both groups. At 2 years follow-up, they find no difference at both groups, the group who were managed conservatively and who were managed surgically. The same group, after 3 years, have done the result extended follow-up up to 5 years, and they still have no significant difference in patient-reported outcome between operative and non-operative treatment. This is another meta-analysis showing operative versus non-operative management. It included 22 studies comprising 7 randomized controlled trials and 15 observational studies. Overall 1,743 patients. The average age was 68, and 75% of patients were women. There was no difference in functional outcome between operative and non-operative. So there is a lot of evidence that there is no difference between operative and non-operative management. So now that what does this mean? This means that we can go back to the sling. There is no benefit of surgeries. I don't think so, but I think the proper assessment of the patient and the fracture morphology type, proper selection of the patient and selection of the management plan will improve the outcome. I think proper surgical technique in plating and arthroplasty result in less complications and failure rates and improve outcome. I think management of complex proximal humerus fractures should be operated in specialized upper limb units. Conservative treatment is still an option in displaced proximal humeral fraction in elderly, especially with lack of experience in operating complex arthroplasty surgeries. Thank you very much.
Thank you so much, Professor Mohamed Salah, for this very comprehensive presentation. Thank you so much. If we have any questions to Professor Mohamed? Okay, we will move to the next speaker. Thank you, Dr. Mohamed. The next speaker will be Professor Amr Ashwan from Cairo University. Professor Amr.
دكتور محمد ازي حضرتك؟
ازي حضرتك يا فندم؟ منور دكتور عمرو بيه.
ازي حضرتك؟
اهلا بيك يا فندم، كل عام وسيادتك بخير.
وحضرتك بخير. دكتور محمد بيه على الدعوة الكريمة دي علشان المشاركة في الكورس بتاع جامعة بنها.
نتشرف بحضرتك يا فندم.
يعني سوكسي عالمي جدا جدا جدا، ناس كتير اعرفها في الخليج وفي الدول الاوروبيه كمان بيتابعوه، فاشكره على اتاحته الفرصه دي ليا علشان اشارك مع حضراتكم في الكورس ده. انا هتكلم على الاكروميوكلافيكولار جوينت انجريز. The optimal treatment of acromioclavicular is still controversial. For many years, the main concern was to restore the coracoclavicular ligament complex, but recently the research interest had aroused towards the acromioclavicular joint capsule and ligament importance. As we can see here, regarding the anatomy of the acromioclavicular joint, it is a diarthroidal joint between the lateral end of the clavicle and the medial end of the acromion, supported by the acromioclavicular capsule with its condensation forming the acromioclavicular ligaments, with the coracoclavicular ligaments, namely the conoid and trapezoid. As we can see here, this is the trapezoid ligament passing posterolateral, and this is the conoid ligament passing anteromedial, being a 1.5 centimeter from the lateral end of the clavicle, and the conoid about 2.5 centimeter from the lateral end of the clavicle. Together, the coracoclavicular ligaments with the acromioclavicular joint capsule and its condensation from the ligaments form part of the superior shoulder suspensory mechanism, which is responsible for the stability of the shoulder joint. This is a cadaveric dissection showing the acromioclavicular capsule, which is responsible for the anteroposterior or the horizontal stability of the joint, allowing for the rotation and the gliding, as well as allowing for the retraction and protraction of the scapula. The acromioclavicular ligaments is formed of two bundles, mainly the superior posterior bundle and the anterior inferior bundle. The main function for the acromioclavicular ligaments is to provide the horizontal stability, namely the anteroposterior translation of the acromioclavicular joint, and also it is a restraint against the posterior axial rotation of the clavicle. Usually the acromioclavicular ligaments fail at first. Their injury occurs during the acromioclavicular dislocation prior to the rupture of the coracoclavicular ligaments. The coracoclavicular complex, as we have said, it is composed of conoid, the anteromedial, and the trapezoid, the posterolateral component, which is the stronger of the two ligaments. Their main function is to provide the vertical stability, mainly the superior inferior translation of the acromioclavicular joint, as well as they provide a rotational stability and the stability with the protraction and retraction of the clavicle. And as we had said, they are more stronger than the acromioclavicular ligaments, and so their failure is on the second step of the failure of the joint. This is the normal coracoclavicular distance, and this is the space where the coracoclavicular ligaments exist. And this is very important during the assessment of the patient with a suspected coracoclavicular joint. This distance is extending from the superior cortical aspect of the coracoid process to the inferior cortical aspect of the lateral end of the clavicle. Rookwood had classified the acromioclavicular dislocation into 6 main types. In the first one, there is a sprain or a partial rupture of the acromioclavicular ligaments. And then the conoid and trapezoid are just sprained and they are intact with no radiographic displacement. Then in type 2, there is a partial, there is a tear of the acromioclavicular ligaments together with a sprain or a partial rupture of the conoid and trapezoid with a very minimal radiological displacement. But in type 3, there is a frank rupture of the acromioclavicular ligaments as well as the coracoclavicular ligaments with a marked radiological displacement. Type 3 is a very debatable, as we will discuss later, with the ISACUS consensus group about the acromioclavicular joint injuries. They subdivided type 3 into type 3A, which is stable, and type 3B, which is unstable. Then we go for type 4, in which there is a rupture of the acromioclavicular ligaments as well as the coracoclavicular ligaments, but with a posterior translation of the lateral end of the clavicle into the trapezius. Type 5, there is complete rupture with a more superior, inferior, or vertical displacement with more widening of the coracoclavicular distance. And finally, type 6, which is a very rare entity in which the clavicle will dislocate under the coracoid process, whether to be subacromial or subcoracoid and beyond the conjoint tendon. As we can see here, this is the X-ray and very evident on this anteroposterior or Zanka views that there is a marked disruption of the acromioclavicular joint. The CT with 3D is very important and is very beneficial because it could provide you with the information about the presence or the absence of a fracture of the coracoid base, which is the main station in the treatment of the acromioclavicular ligaments, whether doing tunnels through the coracoid base or performing loops around the coracoid base for the biological grafts. So a CT with 3D, I think it is mandatory to confirm that the coracoid is intact. As we can see here in this paper, this is a case report in the American Journal of Sports Medicine about the presence of a coracoid fracture in patient with an acromioclavicular joint separation in an American football player. So most probably we will need to do a CT with 3D in patients with acromioclavicular joint disruption to confirm that the coracoid process is intact. As we can see here, this is the mechanism of the acromioclavicular joint disruption, whether through a direct trauma to the lateral end of the clavicle or an indirect trauma as falling on an outstretched hand or on the point of the shoulder. This is the picture of the injury of our famous player, Mohamed Salah. He had a grade 2 or grade 3 acromioclavicular joint disruption during the final match between Real Madrid and Liverpool. As we can see here in the radiological evaluation, the anteroposterior Zanka views are very important to compare the coracoclavicular distance on the both sides with more apparent on the left side the injury. And as we can see here in type 5, the displacement is about 3 times the normal coracoclavicular ligaments. And here in type 3B, as we had said, as classified by Isacus, there is a posterior displacement of the lateral end of the clavicle posteriorly, which means that there is a dynamic horizontal instability affecting the acromioclavicular joint. As we had said, type 3 injuries, this is a controversial issue about the management, divided according to the Isacus consensus group into a stable type A and unstable type B. There is a debate of whether conservative or operative. The dynamic instability is an important issue. Whether it is an acute or chronic, the acute is better than the chronic regarding the operative treatment and also the occupation of the patient, whether he is a military personnel or an athletic population, because in these patients, any dynamic instability will affect the performance and consequently they need to go for an operative treatment, as we had said, going acutely from the start and not to wait to be a chronic injury. This is the full chart of the management of the acromioclavicular joint injuries. As we can see here, the Rockwood type 1 and type 2, the main primary management is non-operative. Type 3 Rockwood injury, we will see whether he is an athlete, he is a military personnel, or he is a high demand or a manual worker. If he is one of this group of patients, then we will go for a primary operative management. If he is not among this group, then we will go for a non-operative treatment for 6 to 12 weeks. If it is successful, then he will return to activity. If it is not successful, then we will go for a secondary operative treatment. Regarding type 4, 5, and 6, they will go from the start towards a primary operative management. The management consideration of the acromioclavicular joint, timing of surgery, we classify the acromioclavicular joint injuries into an acute injury if it is less than 3 weeks. And why less than 3 weeks? Because this is the time required for the acromioclavicular and coracoclavicular joint ligaments to heal, and whether it is a chronic injury more than 6 weeks. And this is debatable because some literature reviews consider the chronic injury beyond 3 months. But in the systematic reviews on the acromioclavicular joint injuries, the early surgery is better than the delayed one because it takes the potential for healing of the native coracoclavicular ligaments and the acromioclavicular ligaments. In the acromioclavicular injuries in the acute cases, the main aim is to approximate the ends of the acromioclavicular and coracoclavicular ligaments in order to achieve healing, while in the chronic cases, the aim is to reconstruct the injured ligaments, and just the mechanical stabilization alone of the dislocated joint will not offer a sufficient power to resist the future loads on such an important joint, and consequently, the use of biological augmentation with grafts, whether autograft, whether allograft, or whether synthetic graft, should be considered to augment the reconstruction in the chronic cases. Regarding the management of the acute acromioclavicular injuries, the main aim is fixation to approximate, as we had said, the coracoclavicular ligaments and acromioclavicular ligaments to achieve healing. This could be achieved through suture tapes, anchors, hooked plate, but the hooked plates need a second operation for removal, whether a coracoclavicular screw, Bosworth screw, but this needs a second operation, and there is many reports about complication and failure in the literature. The use of a cortical flip button, like the dog bone, together with a biological augmentation with semitendinosus or gracilis or palmaris longus tendons through an arthroscopic procedure. This could provide the patient with a high shoulder score regarding the clinical and functional outcome, or fixation with the K-wires. These are the different modalities. This is the Bosworth screw. This is the hooked plate, but it needs removal to avoid the subacromial impingement and its erosion on the undersurface of the acromion, which could lead to a fracture of the acromion, especially in patients with thin acromion. This is the K-wire fixation, but there is a high possibility of migration and failure. And this is the suspension fixation systems. If we go for the chronic acromioclavicular injuries, as we had said, we need a ligament reconstruction of the injured ligaments beyond 6 weeks. This could be achieved through many surgical procedures. One of them is the modified Weaver Dunn, in which there is a distal lateral end clavicle excision together with the harvesting of the coracoacromial ligament and passing it together with a bony tip into the distal end of the clavicle to recreate the coracoclavicular ligaments, or the use of an autograft, namely the semitendinosus, the gracilis, the palmaris longus, the peroneus longus, or use an allograft. And both of these techniques are biological with an aim to provide a better stability for the joint, but it is better than the synthetic grafts. The synthetic grafts, mainly the Lars and the Dacron grafts, they induce foreign body reaction, some persistent inflammation and effusion in the joint, but they are to be considered if the autografts or the allografts are not available. And finally, a new technique, which is a dynamic fixation using the conjoint tendon, namely the short head of the biceps, as a suspension to the undersurface of the clavicle, lateral end of the clavicle, to imitate the coracoclavicular ligaments as a new technique. Here is the harvesting of the coracoacromial ligament, and this is the resection of the lateral end of the clavicle. And here is harvesting of the coracoacromial ligament together with a bone chip from the lateral end of the acromion, and then passing the coracoacromial ligament into the opened lateral end of the clavicle using sutures or suture tapes. The main drawbacks of the modified Weaver Dunn is that the coracoacromial ligament harvested is having nearly 25% of the native power of the coracoclavicular ligaments. The coracoacromial ligament mainly is a part of the coracoacromial arch, and it is a static restraint against the anterosuperior migration of the humeral head, especially in patients with a massive rotator cuff tears. So if we harvest the coracoacromial ligament in patients with massive rotator cuff tears, this will allow for an anterosuperior escape of the humeral head. And finally, the vector or the line of pull of the transferred coracoacromial ligament does not coincide with the vector of the native coracoclavicular ligaments. This is a case presentation. This is the clavicle with the two tunnels prepared, and this is a harvested semitendinosus. And here, passing the semitendinosus graft around the coracoid process and passing them through the bony tunnels into the lateral end of the clavicle and tying them together, and then using the excessive length to reconstruct the acromioclavicular ligaments across the acromioclavicular joint space, and then resuture it on itself. So we have reconstructed the coracoclavicular as well as the acromioclavicular ligaments. As we had said, the main trend is towards the arthroscopic surgery today, using the suspensory devices with or without a tendon graft. What are the main advantages of this technique? That there is no need for removal. Using the arthroscope, we can address any associated pathology with the injury of the acromioclavicular joint, as well as it offers the patient a very excellent scores regarding the functional outcome. However, the drilling through the clavicle and then through the coracoid carries the risk of the fracture of the clavicle or the coracoid, as well as the risk of tunnel dilatation through the movement of the suspensory system. the use of or the combination with a biological component through the use of a palmaris longus, a semitendinosus, or a gracilis tendon, or a peroneus longus tendon, being looped around the coracoid and then looped around the clavicle could provide a more stronger fixation for such a system without the risk of drilling through the clavicle using the tunnels. Here I will be presenting a case of acromioclavicular joint dislocation. This is the preparation of the undersurface of the coracoid. We are viewing through an anterior anterolateral portal, and this is the radiofrequency removing the preosteum from the undersurface of the clavicle till exposing the base of the coracoid process, and using the shaver to properly expose the undersurface properly. Here is the undersurface of the coracoid process being exposed. And then the introduction of the guide for the reconstruction. Here is the guide for the acromioclavicular joint. And then drilling, as we can see here, the wire had passed through the base of the coracoid process. Then through the anterolateral portal, we can confirm the exact position of the drill tunnel at the base of the coracoid process. This is the cannulated dreamer. And then we pass through the cannulated dreamer the nitinol wire, flexible wire, to be retrieved through the anterior portal, because it will be used to shuttle the suspension system. Here we are passing the suspension system, and here it is flipped on the undersurface of the coracoid base. We make sure that it is properly fixed on the undersurface of the coracoid, and here the sutures are being tightened, working on the clavicular side above. And here is finally, we will retrieve the passing sutures, which had guided the button through the tunnel, through the clavicle, then through the coracoid base. And here is the button properly fixed on the undersurface. This are an intra-operative C-arm views, showing the flip button on the undersurface of the coracoid and the suspension button on the upper surface of the lateral end of the clavicle. And this is the post-operative X-ray. And here is the passage. Sorry, this is not working. About passage of the biological augmentation. Another technique is to do a cerclage wiring or a cerclage tape around the lateral end of across the acromioclavicular joint to augment the suspension fixation by many techniques, using the tapes, using suture wires, or even using the biological graft and passing the extended length across a hole in the acromion, and then resuture it back on itself at the posterior aspect of the clavicle, thus reconstructing the superior and the posterior capsular ligaments. This provides a better horizontal stability, better long-term results, and better functional outcome. Now, the more common techniques is using a patch augmentation, whether with dermal xenografts or dermal allografts, to reconstruct the acromioclavicular joint with button stabilization. This is the literature review around the use of the tightrope fixation, that it is much better than the hook plate fixation in the acute unstable acromioclavicular joint dislocations. To summarize it up, our take-home message that treating the acute or chronic acromioclavicular injuries is a challenge to the orthopedic surgeon. We should take care of the presence of a coracoid fracture because it is the mainstay in the treatment of the acromioclavicular joint dislocation, and also don't miss the lateral endoclavicle fractures as an acromioclavicular dislocations. Different modalities of acromioclavicular joint dislocations, fixation and reconstruction. Many techniques try to be familiar with most of these techniques, but there is no consensus about the best technique or the best management of such a challenging type of injury. The arthroscopic acromioclavicular reduction and fixation using the tightrope together with an augmentation with a biological graft is a very recent and effective modality for the acromioclavicular joint dislocation. Thank you.
Thank you so much, Professor Amr Ashwan, Cairo University, for this very interesting talk. If we have questions to Professor Amr, Dr. Raffaelli, I see you. Do you want any questions? Okay, thank you so much.
No, I really think that Dr. Amr Ashwan did a fantastic presentation. It's a kind of pathology that we have a lot of doubts yet.
Yeah.
And these changes of fixation in horizontal and vertical fixation to improve the stability of the acromioclavicular joint, for me, that's a very good way to treat this pathology. Congrats.
Thank you.
Thank you, Dr. Raffaelli.
Thank you for both all. Thank you so much. Now we will move to the final step in this day. It's a recorded surgery offered by Zimmer Company. It will be presented by Professor Hussam El-Bigawi. Professor Hussam will give a short note on the recorded surgery, and then we will move to the recorded video. Professor Hussam. Dr. Amr, would you please stop sharing screen, sir?
Okay. Sorry. I think I stopped the share.
Yes, sir. Thank you. Dr. Mohamed, you are ready with the video? Just one moment, we are preparing the video.
السلام عليكم.
Salam alaikum, Dr. Hussam. I'm asking for the video to be, yes. Dr. Hussam, you are ready? Dr. Hussam? يا دكتور حسام ايه انت ما تدخلش ليه؟ حبيبي طيب اوكي حسام هيشغل فيديو دلوقتي اوكي ماشي يا حبيبي. سوري just one moment في technical problem بس في الفيديو يا فندم هنعرضه على طول.
والمرات بنعمله نجيب الطباخ هنا.
صوت شغال يا فندم؟
صوت الفيديو مش شغال يا دكتور حسام.
كده يا فندم شغال؟
السلام عليكم.
السلام عليكم وبركاته. اتفضل. عايزين نتاكد بس ان الفيديو شغال لان انا جربته كان شغال كويس.
كده يا فندم صوت واضح؟
لا.
مش واضح؟
دكتور حسام احنا ممكن نشغله وحضرتك تقول الكومنت اللي عليه يا فندم.
السلام عليكم.
اتفضل يا دكتور حسام.
ازيك يا دكتور محمد؟ احنا معلش انا اسف التكنيكال بوينتس ديت كان في مشكله في
دكتور حسام
في النت هنا. سامعني كده يا دكتور محمد؟
كده سامع حضرتك. اتفضل يا فندم. لا الصوت مش واضح يا دكتور حسام خالص.
طب ثانية، طب اقفل يا فندم الشير واعمل في الشير تاني. ثانية واحدة يا فندم كده، عمرو هيفتحه من عند اللاب بتاعه دلوقتي يا باشا ان شاء الله.
اوكي.
السلام عليكم.
السلام عليكم وبركاته يا دكتور حسام.
دكتور محمد ازي حضرتك؟ يعني من حضرتك نهنئ حضرتك ونهنئ انفسنا بالنجاح بتاع الكورس والعماده ومش عارفين.
ربنا يخليك يا حبيبي.
ربنا يكرمك يا دكتور محمد.
خليك يا حبيبي.
هو الفيديو بتاعنا ده يعني موجه اكتر لطلبه الماجستير والدكتوراه. المفروض ان هم يعرفوا لان هم بيمتحنوا الابروتشز بتاعت الشولدر والتكنيكال بوينتس. فاحنا في كذا بوينت عايزين انهم يعرفوها قبل ما ايه يعني ناخد بالنا منهم قبل ما نبدا الفيديو. اول حاجه الابروتش، اللاند ماركس والانسيجن والديسكشن واليوز اوف ريتراكتورز، وبعد كده البروسيدور ازاي يظبط الانتي فيرجن بتاع البروسيسز، وازاي how to use the trials and post operative rehabilitation. فان الاسئله اللي في مصر تكون عندهم اجابه لها. فنبدا الفيديو واحنا ماشيين ان شاء الله هنبقى نتكلم عنها. اتفضل يا حسين.
حسام عرفت شغال ولا لسه؟ لا مفيش صورة يا حسام.
نعم؟
لا بقول سوري، بقول لحسام حسام الاكسيد. عمرو مفيش صورة في الفيديو. حسام الاكسيري انت عندك تكنيكال بروبلم في الفيديو؟
ايوه يا فندم. هو يا فندم دلوقتي هو عامل رفعه من على اللاب بتاعه.
ممكن.
اصل انا شغلته كان شغال كويس مفيش مشاكل يعني.
ولا طب حاضر يا فندم، اشوف كده مع عمرو كده واتكلم حضرتك نبقى حضرتك على طول.
لو احنا عندنا تكنيكال بروبلم ممكن نخليه بكره ان شاء الله مفيش مشكله يعني يو سولف ذا بروبلم ونكمله بكره ان شاء الله السكند داي.
تمام. حاضر يا فندم، ثانيه واحده كده.
طيب شوف اللاست ترايل كده. احنا بكره ان شاء الله عندنا السكند داي. احنا معانا بكره lots of eminent speakers. معانا بروفيسور ماهر العسال من اسيوط يونيفرسيتي، بروفيسور حاتم جلال زكي من اسيوط يونيفرسيتي، بروفيسور عبد الرحمن الجنايي من المنصوره، بروفيسور محمد صبحي من عين شمس، بروفيسور معين خان من ماكماستر يونيفرسيتي كندا، بروفيسور عمرو قنديل من المنوفيه ان شاء الله. فانا هشوف بس الفيديو في بروبلم. ايوه حسام عرفت تشغله ولا في بروبلم؟ احنا بنعتذر لحضراتكم ان في تكنيكال بروبلم في الفيديو نفسه، هينزل بكره ان شاء الله في السكند داي. انا اسف يا دكتور حسام معلش هم مش عارفين يحملوه من الموقع نفسه فهينزلوه على الجهاز ويشتغل بكره ان شاء الله. فاحنا بكره ان شاء الله هنبدا الداي 3 الظهر 3 بي ام لحد 7 مساء لحد 7 بي ام ان شاء الله. هيبقى معانا 8 سبيكرز بكره ان شاء الله في الديفرنت انتيتيز والديفرنت توبكس في الشولدر سيرجري. فنأسف على العطل ده، وان شاء الله بكره الفيديو يتذاع ونرى حضراتكم بكره الساعه 3 العصر باذن الله تعالى. شكرا، متشكرين يا فندم، تصبحوا على الف خير. شكرا يا فندم.
حضرتك من اهلا دكتور محمد، ميرسي، شكرا جزيلا.
شكرا يا فندم، شكرا دكتور عمرو بيه، متشكرين يا فندم.